Hi, this is Divya Prakash from nuclearmedicinessolutions.in. We are discussing currently NABH accreditations of hospitals and diagnostic centers. And this is the fourth and last part of the video where we will be discussing about quality indicators and what are the documentations are required for those quality indicators. This video series had 4 parts where in the first part we discussed about what is quality in healthcare. In the second part we discussed about accreditation organizations and their standards. Based on those standards, what are structural, procedural and outcome related needs we discussed in the third part. And now we are going to discuss about quality indicators. Just a quick reminder, we discussed what is quality in healthcare. In first part we discussed quality building blocks, the need and the benefits of quality. In the second part we discussed about healthcare accreditations across the world, in India, NABH standards and their various requirements during different stages. We discussed the chapters of NABH standards for hospitals and medical imaging services. In the third part we discussed statutory compliances, we discussed structural requirements, we discussed the documentations, and we saw the sample documents also. So let's start and discuss what are quality indicators. They are measures of any quality program. They are standardized, evidence-based tools to track clinical performance and outcomes. It uses readily available administrative data to help decision makers to call for action. It allows to track the quality changes over time and are backbone of quality assurance program. We'll see an example how the quality is changing over the time, and that we are monitoring, that we are seeing with these quality indicators, and then based on those indicators we will be changing our course of action, or we will be changing the way we handle the patients, the way we interact with the patients. Those all the things can be modified based on those quality indicators. Let's see what are the quality indicators you can set in your department. These all are just examples. You can set as whatever you wanted to do. You can set a quality indicator which indicates the percentage of turnaround time for startup procedure. Any patient who comes to the hospital or imaging services, they wanted their procedure to start as early as they come. So that thing you can monitor by calculating total waiting time of all the patients from time of reporting to start of procedure divided by total number of patients whose waiting period has been recorded into 100. This is all you can get system generated records. You can take percentage of appropriate communication of critical results to referring physicians. There are number of conditions where the referring physician need to know urgently and take action, so he should be informed immediately whenever the test completes. And the formula you can take it total number of times inform the critical cases in stipulated time divided by total number of cases reported in a month. There are number of conditions like pulmonary embolism, GI bleed studies, HIDA bile leak in liver transplant cases, testicular torsions, renal transplant rejections, and sometimes mecadiverticulum. So there are a number of other cases which can be there for other imaging services. You can figure it out from the doctors that which all the conditions are required to be informed. You can calculate patient satisfaction score. This is the best quality indicator of any organization. The patients should be satisfied. And how can you quantify that? You can take feedback from patients where patient can give feedback in scores like 5, 4, 3, 2, 1 scores, and based on those scores you can give some weightage on each numbers and you can calculate the patient satisfaction scores. And the formula can be sum of scores given by patients into numerical value on a scale divided by score given by patient into 100. Like that you can keep maintenance of radiation survey level within permissible limits. You can take percentage of adherence of TAT for reporting, means whenever the test gets completed and how much time we are taking to deliver the report, that turnaround time can be calculated and keep it as a quality indicator. The number of reporting errors per 1000 investigations, that we can take it as a quality indicator. The number of contrast reactions per 1000 patients, the patient's fall rate per 1000 patients, percentage of misadministrations within a defined time period, needleistic injuries rate, percentage of medical errors due to wrong identification of patients, percentage of rescans, and employee satisfaction index can also be taken as a quality indicator, where we can take average ratings given by employee to the organization, and that index can be calculated for different categories of employees. So let's see the examples of each quality indicator. What are the documentations we need to make? We need to prepare an SOP for that quality indicators, where we will be mentioning about the purpose, scope, process, and how those calculations will be ascertained. These things has to be mentioned in that standard operating procedure. Once we have SOP, we need to have measure information form, which will have the rationale for that quality indicator, the working formulas, how are you going to collect the data, and what will be unit of measure, what will be sample size, and what will be frequency of data recording, and all the details should be mentioned in that measure information form. Then we need to have an action plan to improve that quality indicator. After that, we need to have quality improvement priority grid, means if you are going to improve that quality, what will be your priority to improve that. Criterions can be patient's needs or expectations, patient's outcome, strategic plan, regulatory compliances, cost to implement, impact on efficiency or budget, patient volume affected, patient's risk, problem prone, and based on these all the sections you can give scores, and if the score is coming more than 18, then it is a top priority. If it is 14 to 18, it is a moderate priority. Like that, you can set your priorities based on which you will be improving your quality indicator. Then we need to keep a target value and the threshold value, means this much of target we need to achieve for this quality indicator, and below the threshold value our quality should not fall, and if it is going below that, we need to take an immediate action. Then we need to have a data recording form. Like this is the example of critical patients information to the referring physician. We need to have a form which will record about patient's name, age, sex, UHID, name of investigation and date on which the investigation was carried out, who was the referring consultant, what was the critical finding, who conducted that investigation, and the time of obtaining results, and then the critical findings were conveyed to whom and at what time, and who was the reporting staff to that referring physician. This all the details should be there for all the sample patients. And then we need to have a data collection sheet. This is the example of patient satisfaction score, where our data is showing this, all the values are imaginary values, and suppose in the January we had and averagely we are given around 4.8, and then it started falling, then it goes like this. During June 19 it fell down below the mean value, then some action was taken by management, then it improved again. During September it started falling, in October again it fell, then some action was taken to improve those indicators, and in December 19 you came back again to around mean value of your patient satisfaction score. This is the mean value, and this is upper control limit, this is lower control limit. This upper control limit and lower control limits are mean plus 2 standard deviations and mean minus 2 standard deviations. So our data should fluctuate between these two upper control limits and lower control limits, and it should not go below the threshold level. Then once we have all these quality indicators, all the documentations, all the infra related needs, then we need to fill this self-assessment toolkit which is there on their website. There we need to give scores of all these points, whether we have documentation, yes or no, whether we have implemented those things, yes or no. Based on those things we need to give scores to us, and it can be 0, 5, 10. If the documentation and implementation everything is not there, then it is 0. If the documentation is there, implementation is not there, then it is 5. If both the things are there, the score will be 10. Like that, it is a 18-page data where you need to give scores to ourselves, and it is a self-declaration kind of thing where you intimate to the NABS that you have this all the things. Once it is done, then we go for pre-assessment inspection, and whatever non-conformities comes in that, once you close, you go for final assessment. Then again NC is closing. Once the NCs are closed, you are NABS accredited, and after certain period you will be going for surveillance audit, and then before 6 months of expiry of your accreditation period you will be going for re-accreditation process. And finally you will be given this certificate which will have your center name and address, and it will be signed with the CEO of NABH with details of your certificate number and validity with the list of scope of services. So thank you very much for your patient hearing. Please feel free to write us at support@nuclearmedicinesolutions.in. Thank you very much.